Hey guys, Mike back with you. One of the questions we're always asked is, hey, when is a review course going to come to my area? The best resource for you is to check FlightBridgeED.com. Courses are being updated almost daily. If there's not one coming next to you, guess what? We've got the fully accredited online university where you can take courses from FlightBridgeED, FoamFrat, and the list goes on. So check out FlightBridgeED.com today for more information.
The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, welcome back. We're going to go into the pathophysiology of this virus. So let's just jump into how is it spread. Well, we know it is obviously spread airborne, respiratory droplets. We know it can stay in the environment for up to 3 hours. But we also have to remember that it can be spread fecally. And then obviously through that oral route. So that's why it's so essential. You know, you use the bathroom, you wash your hands. If you're traveling, if you're out and about, and you're going to any bathroom, or you're touching anything that somebody else could have touched, that we have to continuously wash our hands and use hand sanitizers, things like that, to try to prevent the spread via that route. We know that the distancing side, if somebody sneezes, if you are within 3 to 4 feet of that person, then you could definitely contact it through that respiratory droplet side. So how does the virus attack? Well, we know that the virus can be benign, that you may not have any symptoms at all. So when we go through the pathophysiology in this podcast, we have to understand that I'm going to go to the extreme. I'm going to talk about the patient that ends up on the vent. I think that is where the healthcare industry itself is looking at from the standpoint of, can we flatten that curve? It's not the patients that go home and self-isolate and have, normal flu-like symptoms, mild respiratory symptoms, cough, congestion, fever, things like that. It's the patient that ends up in the ICU on the vent. Do we have enough hospital beds, ICU beds, ventilators in the United States that can handle this? And we have definitely seen that is not the case. And Italy has definitely struggled in that area. So I'm going to talk about the more severe onset, these patients that end up on the vent. And how does that happen? Well, a lot of the things we're going to talk about, ironically, are very, very normal in how we see patients progress into ARDS and sepsis and MODS. So I'm going to go through this, and there's definitely other podcasts we can refer back to, but I am going to go through this and kind of break this down in a systematic approach. So we know that the virus attacks the lungs. Obviously, we get a patient that presents with that initial potential fever. They may have a cough. They may have some shortness of breath. There are patients where you may have nausea, vomiting, diarrhea. They're atypical presentations. So that starts the whole process. Well, then the virus attacks the lungs. Well, how does it do that? Well, it attacks the type 1 and type 2 pneumocytes. Type 1 pneumocytes are really about gas exchange. Type 2 pneumocytes we know is all about surfactant production. So we see an attack on those pneumocytes, and that is what's going to start this release of inflammatory mediators. And inflammatory mediators are these big macrophage cells, and they secrete what's called a cytokine. And two specific cytokines that they release are called interleukin 1 and interleukin 6. And interleukin 1 is really about fever, and it stimulates the hypothalamus, promotes formation of just really these amazing disease-fighting cells. So we see a release of interleukin 1, interleukin 6, these cytokines. This starts breaking down and we've talked about this in other podcasts, if you've taken our review courses, it starts breaking down the endothelial cells in around the alveoli and the capillary beds. Remember, we've talked about the endothelial glycocalyx, the little hair-like projections that protrude off of the endothelial lining. And that is what maintains this great oncotic pressure. And so now you have a breakdown. That glycocalyx is destroyed. You have vasodilation that occurs. This causes a big increase in capillary permeability, and this interstitial fluid creep starts happening. Well, so now imagine you have all this fluid that is filling the space between the alveoli and the capillary bed. Your alveoli becomes compressed. We have a high compression against the alveoli. Not only do we have fluid creep in and around the alveoli, but we have fluid creep into the alveoli. And we know that that disrupts the water surface tension that is maintained by surfactant. And so if we have that water surfactant ratio disruption, the water surface tension skyrockets. And now we have a huge increase in surface tension, and that leads to collapsing pressures that increase significantly in our alveoli collapse. Well, when we think about alveoli, think about that we have about 600 million alveoli. And that is happening globally. And that's the thing we have to understand, is this is a global attack on the lungs. This is not just one alveoli. And so we see this global alveolar collapse. The inflammatory mediators then pull in these neutrophils. And neutrophils, we know, try to attempt to destroy the virus. But it causes a secondary problem. It causes a high release of what's called oxygen-free radicals, or reactive species. This actually leads to further cell damage. So what happens? Well, this is where you start seeing global hypoxia that starts. If we go all the way back and we think about those cytokines, the interleukin 1 and interleukin 6, the interleukin 1, as I said, and interleukin 6, they actually also have a secondary response to our central nervous system. They stimulate, specifically interleukin 1 stimulates that hypothalamus. That's what causes that fever to ensue. So let's think about what your patient is going to look like. They're going to definitely have a fever. This is going to be more progressive. Cough, it's usually dry. Difficulty breathing. As I said, atypical presentations. They may have some nausea, some vomiting. They may have just a runny nose, congestion, things like that. But when we think about the secondary effects, they're going to be hypoxic. Well, what happens there? Well, obviously we have pulmonary shunting. And remember, your body's ability to deliver oxygen, DO2, the delivery of oxygen every single minute, is the sum of the content of oxygen in our arterial blood. We have to deliver that. We have to deliver that based on a normal minute ventilation, normal diffusion rate, and we have to have a proper cardiac output. Well, that hypoxia is global now. If we look at an ABG, remember that initial response, you're going to see that uncompensated respiratory alkalosis. Their PaO2 is going to be low. Well, what is going to happen? The patient is going to have this huge response. This stimulates chemoreceptors. And those chemoreceptors increase the sympathetic nervous system. So your patient is going to have an elevated heart rate. They're going to have an elevated work of breathing. They're going to have an increased respiratory rate. They're probably going to have some sort of increase in tidal volume. Well, remember that in response to that hypoxia, that chemoreceptor response. So let's go back and relate this to a patient that you might see. So you have a fever, they're going to have some difficulty breathing, obviously cough. But that more progressive patient that comes in, their work of breathing is going to be increased, the respiratory rate is going to be higher, tidal volume is going to be higher. That is in response to that hypoxia. Well, what is that ABG going to look like? Well, as I said, that initial presentation when they start increasing in their disease process is most likely going to be an uncompensated respiratory alkalosis. Remember, if our work of breathing increases, we breathe faster more often, we're going to blow off more CO2, and that's what leads to that response. If we go back and relate this to other education we've done, remember that would be what we call a venous admixture, and we would have to intervene. And so remember the three types of gas laws that we really focus on is we have to understand that if we have a patient that is having a pulmonary shunting phenomenon, we're not getting the O2 molecule down onto the red blood cell where it can attach to the hemoglobin, i.e. remember that is the content of oxygen in our arterial blood. If we can't get that O2 molecule to where it needs to ultimately live, the hemoglobin, and then where that hemoglobin can release it to its areas of need, then we have a huge, huge problem. So that pulmonary shunting needs to be fixed. We talk about this in all of our courses. Number one, we have to think about the simplest thing, and that is to increase the partial pressure. Well, we already know the hypoxemia, the chemoreceptor response is in relation to that low PaO2. So that PaO2, little AO2, the partial pressure of oxygen in our arterial blood is low. Well, let's increase it. So let's turn up the gas. So if we increase the FiO2, that initial response is going to be that we are increasing the partial pressure. Now, what does that do? That increases the pressure above the gas over the solution. Remember the definition of Henry's law. The amount of gas dissolved in the solution is directly proportional to the pressure above the gas over the solution. So if I change that up a little bit and I say the amount of oxygen dissolved in the capillary blood is directly proportional to the pressure above the oxygen over the capillary blood. What we just did by increasing the partial pressure, which is Dalton's law, is we put a higher amount of pressure. So that is going to optimize what we call solubility. And Henry's law is the gas law of solubility. So the definition I just said, the amount of gas dissolved in the solution, that definition is the definition of Henry's law. You're optimizing the solubility of that gas. So how does that O2 molecule ultimately end up in the liquid? And what is its diffusion potential into that liquid? So number one, we increase the partial pressure by optimizing Dalton's law. That starts the process of optimizing Henry's law, the solubility. Number two, we have to increase the surface area. We do that by applying Fick's law. Fick's law is a gas law that says that if we increase the alveolar size, we do two things. Number one, we increase surface area. That allows for more diffusion potential or area of diffusion. And number two, we thin out that alveolar membrane. That causes a faster rate of diffusion across that layer. Well, how do we do that? Well, these patients obviously are going to end up on the ventilator. They're going to need to be intubated, so we need to optimize that and be aggressive in recruiting that alveoli with our inspiratory phase and then maintaining that functional residual capacity at the end of exhalation with PEEP, and that is optimizing that Fick's law or step 2. And step 3 is going to be applying more pressure above the gas over the solution. That's where we're really giving some extra measure in optimizing the pressure above the gas. So obviously the mechanical ventilator is doing that for us. So by thinking about this very definitively, step by step, optimizing the partial pressure, optimizing the surface area, optimizing the solubility, we then start potentially turning this disease process around. Well, we know it's not that easy. And as we said, the delivery of oxygen every minute is the sum of the content. Well, by going through the 3 steps that we just talked about, that is hopefully optimizing that CaO2, hopefully increasing our PaO2. Remember, we have the other side, and that is our cardiac output. Well, let's talk about that. Because of the hypoxia, because of the stimulation of the chemoreceptors and the increase in heart rate, the increase in work of breathing, etc., we're now going to see this globally spread. This inflammatory response now becomes a systemic inflammatory response. That's going to cause essentially a capillary permeability globally to dilate. And that vasodilation globally is going to reduce our blood pressure. Patient is going to become hypotensive. This is now going to be looked at as more of a sepsis. So, the patient starts off with just a virus, and then they progress to those mild symptoms of that cough and fever and shortness of breath, and then they may progress to the increased work of breathing. Well, if we have a patient that is now globally in that systemic inflammatory response, and they have global capillary leak, that is going to be catastrophic. So if we recap how this disease process went along, we had the virus, we have transmission, starts off as maybe a mild dry cough, then fever, again, other symptoms. They may have an increased work of breathing, difficulty of breathing, but remember, don't discount the whole nausea, vomiting, something that Ashley has talked about in other podcasts. She has been right multiple times, all the time. Our son will get strep throat, have a sore throat, has no other symptoms, but mild nausea. She will diagnose him well before a swab with strep throat, take him in, he gets swabbed, strep throat. So remember, the secretions, if we have a lot of secretions going down into our gut, that makes us nauseated, and that can also always lead us back to a respiratory type of disease. So you have the virus, you have the cough, the dry cough, that leads to, maybe a increased work of breathing. Don't forget the whole nausea, vomiting, potential diarrhea. Well, maybe that then progresses to pneumonia, which, we're going to look at in the clinical diagnosis section, where you have maybe some opacities. And then we end up in ARDS. And then we have the systemic response, and that leads us to sepsis. That leads us to a global vasodilation based on that increase in capillary permeability. And that leads us to hypoperfusion and hypotension. Well, that's going to then cause a big reduction in perfusion to our kidneys, our liver, and that's going to lead to multi-organ dysfunction and death. So that is how our patients will progress, and they progress very rapidly once that hypoxia, that breakdown of those type 1, type 2 pneumocytes become global. So we have to be very, very good about trying to pick up on this early. We're going to go through the clinical diagnosis. I'm going to have Ashley on the podcast. We are going to do this together. I definitely want her involved in that. She definitely has seen patients in the ED, and I definitely think that we can learn a lot from both sides, whether you're pre-hospital, whether you're in the ED or the ICU. We need to look at this from all angles. And so hopefully this was beneficial, and we will see you on the next episode. Please stay safe, and I will talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.